Here is a case of phacoemulsification of patient with narrow pupil and peripheral corneal opacification. What happened while extracting the pupil expander ring? It was entangled with the iris tissue, as we can see. Let's watch this case together. Here is the pupil. You can see it's small pupil. Look at the opacification at the periphery of the cornea. Look at the haze of the cornea. Here is the pupil expander ring implantation. Actually, this is Malyugin ring to dilate the pupil. Now, as we can see, I have about 6 millimeter pupil diameter, which is good for doing 5.5 millimeter capsular rhexis. The capsular rhexis forceps doing the anterior capsular flap and complete the capsular rhexis, as we can see. Look at the density of this cataract. Actually, this is the only seeing eye for this patient. Now I have 5.5 a capsular rhexis size, well centered, then doing the hydro dissection, hydro delineation, and also visco dissection. Then rotate the nucleus to be sure it's free. Now it's the time for emulsification of this dense cataract. As usual, I prefer to use a horizontal chop, holding the nucleus and go by the chopper to the close to the equator and bring it towards to the phaco tip. Actually, the first trial was failed. Here's the second trial. Again, it's failed. Rehold again and chop. Now it's good. So complete chopping of this dense nucleus into small fragments. Then you can emulsify each fragment alone at the superior nuclear space, just at the level of the pupil, away from the back of the cornea. And also crucial step is to re-inject dispersive OVD while emulsifying this dense cataract to protect the back of the cornea, as we need a high ultrasound energy for dense cataract. Here is the end of emulsification of this cataract, the posterior shell of the epinuclear and the cortex. Everything is good until now. Gently and smoothly aspiration of this posterior shell. Now go out, and it's the time for bimanual irrigation aspiration. Actually, keep the anterior chamber stable and maintain the stability of the anterior chamber and the capsular bag while removal of the cortex. As we can see, the cortex is stuck with the posterior capsule, and look at the flattering of the posterior capsule, which is a sign of weakness of the zonule. As we can see, look, the cortex was stuck with the posterior capsule, and look to the flatter movement of the posterior capsule. Now injecting cohesive OVD to implant a 3-piece IOL after enlarging the main phacoincision. I put the haptic in the sulcus and the optic capturing the rhexis because there is mild weakness of the zonule. Now it's the time for removing the Malyugin. So I free and release the distal part of the eyelid and fix it with the injector of the Malyugin. Then while extracting the Malyugin out, look, here the proximal eyelid was stuck and entangled with the iris tissue. This is a conventional way of ring removal. So let's go to the normal and the conventional methods. Here you can see free and release the distal part, then free the proximal part, then hold the proximal part with the injector of the Malyugin, then pulling the Malyugin out while extracting the injector out the antechamber. Let's back to see our case. Here I released the distal part and I fixed the distal part without releasing the proximal part. That's why the proximal eyelid of the Malyugin ring was entangled with the iris. So now the time for washing of the OVD anterior and behind the IOL, and be sure that your optic is capturing the capsular rhexis, then doing the stromal hydration for the paracentesis and main phacoincision. On the next day, the patient was happy with Vision 2020, and thank you for watching.